District 3 City Council, and I'm the chair of the Boston City Council Committee on Public Health, Homelessness, and Recovery. Today is July 11th, 2024. This hearing is being recorded. It is also being live streamed at boston.gov/city-council-TV and broadcast on Xfinity Channel 8, RCN Channel 82, and FiOS Channel 964. Attendance in accordance with Chapter 2 of the Acts of 2021, modifying certain requirements of the open meeting law and relieving public bodies of certain requirements, including the requirement that public bodies conduct its meetings in a public place that is open and physically accessible to the public. The City Council will be conducting this hearing remotely. This enables the City Council to carry out its responsibilities while ensuring public access to its deliberations through adequate alternative means. Written comments may be sent to the committee email at ccc.health@boston.gov and will be made part of the record and available to all councilors. Public testimony will be taken at the end of this hearing. If you're interested in testifying, please email our central staff liaison, Cora Montron, at Cora, C-O-R-A, Montron, M-O-N-T-R-O-N-D, at boston.gov for the link, and your name will be added to the list. Today's hearing is on docket number 0478, order for a hearing on provisions of temporary mental health treatment or interventions and preventions for children and youth before formal diagnosis. This matter was sponsored by Councilor Tanya Fernandez-Anderson and was referred to the committee on March 6, 2024. Today I'm joined by my colleagues in order of arrival, Councilor Braden, Councilor Worrell, Councilor Mejia, Councilor Coletta Zapata, and of course our sponsor, Councilor Fernandez-Anderson. Councilor Fernandez-Anderson, I don't know if other folks have opening remarks, but I'd like to just give you a chance to have an opening remark because I know there's a lot of big words in the docket order. So just what you would expect out of this and sort of a brief description so both the panel and our colleagues know. And if there's no other testimony, we'll go right into the, if there's no other opening remarks, we'll go right to the panel testimony. But sponsor Tanya Fernandez-Anderson, please, floor is yours.
Good morning, everyone. Thank you, Mr. Chair, for the courtesy, and thank you for working with our office to hold this hearing. When it comes to youth mental health, the data is alarming. And as someone who previously worked in the mental health field for over a decade, working with children behavioral health services in home and school-based therapeutic services, I am deeply invested in this conversation today. Around 36% of Massachusetts youth ages 0 to 17 experience at least one form of trauma or significant stress in the prior years, with almost 14% experiencing multiple traumas. And from 2015 to 2021, the percentage of public high school students reporting persistent sadness increased from 26% to almost 44%. According to the city's own Health of Boston report, the same Health of Boston report found that there were larger increases among teen girls and among Latinx and LGBTQ plus students. However, because a young person feels sadness does not mean that they will seek treatment. According to one study, nearly 60% of youth with major depression do not receive any mental health treatment. One of the reasons our office identifies as why young people don't seek to treat has to do with barriers, stigmas, of course, associated with obtaining a formal diagnosis. Feeling depressed is one, but being diagnosed with depression is entirely another thing. Our goal for this hearing, and I just wanted to point out that the other issue is that with any treatment to be paid by your insurance, it has to be deemed a medical necessity. So then, you do have sort of, codes that are depressive NOS types, and they're less harsh diagnosis. Which does not imply a disorder, and it indicates that it's a temporary or circumstantial situation. However, it's still a diagnosis. It's still recording on record. Whereas the children that I've mentioned here in the data in the research their counterparts in the suburbs, folks in more affluent backgrounds, have more homeopathic or natural resources that support them in their treatment. For example, exercise facilities, whether it be yoga or other types of non-traditional medicinal practices that have been proven to be effective as well. So the idea is, are there services that we are currently doing? If so, can we talk about, hopefully this is a conversation today, can we talk about how we can scale to provide more services like that, that children don't necessarily have to, if they're afraid of stigmas, they don't necessarily have to deal with the fear of being diagnosed. But also, if that's not the case, then for children who are going through insurance, or for children that perhaps in school, getting school-based services, could there be services that don't necessarily need a diagnosis, just to sort of triage the situational or temporary circumstantial condition that they are going through before you complete the comprehensive assessment, or before clinicians and practitioners complete the comprehensive assessment, that they at least allow the grace to understand and get to know. And I think 3 months is sufficient time to do that. Again, a harsh diagnosis or a disorder follows you for the rest of your life. And if you're just going through something temporarily, you don't need to be deemed oppositional defiant disorder, which is something that follows you forever. Instead, mom just lost her house, and temporarily within these few next months, I'm homeless with my family, so that's why I'm feeling sad and anxiety, and I'm opposing to authority figures or whatever. I appreciate the time for me to open up and give context to what the conversation should be, and I hope that we can hear from the panelists and my colleagues and have a robust conversation. Thank you.
Thank you, Councillor. As for opening remarks, I'll just leave it if anyone would like to. Councillor Braden, Councillor Morella, Councillor Coletta Zapata, if you'd like to say something. Councillor Braden, go ahead.
I'll keep it very brief. I want to thank Councillor Fernandez-Anderson for bringing this very important topic up for discussion. I know from my own life experience that you, as a young person, you experience what we call temporary mental health challenges due to life crises, family situations, social things that are going on. Like when I grew up in Northern Ireland, we had some pretty horrendous things happening. And I think one thing that my experience is that we all tended to self-medicate. We got a hold of alcohol. I didn't do anything else other than alcohol, but at a pretty young age, I was trying to self-medicate with alcohol and cope with stress that we had absolutely no supports. We didn't have counsellors in school. We didn't have absolutely nothing. So you're thrown back on your own resources in a way and cope the best you can. I feel that we have a huge amount of resources in Boston. I think it's a question, as Councillor Mejia would always say, of connecting people to the resources, but also just as Councillor Fernandez-Anderson is that grace period of realising, you're going through a rough patch. You don't necessarily have a mental health diagnosis that's going to carry with you for your lifetime, but you do have challenges. In some cases, those challenges can lead to a more serious mental health situation, like persistent depression, profound depression, and even suicide if it's not treated. But I think this is a really important conversation to have this morning, and I really want to appreciate and thank Councillor Fernandez-Anderson for bringing this forward. It's hugely important to our young people. Thank you.
Thank you, Councillor Braden. Seeing and hearing no other need for opening statements now, unless folks would like to chime in. Last chance. I'd like to get to the panel, given that.
Oh, sorry. I'm sorry, Councillor Fitzgerald. I'm not sure if you saw that I was here too. So.
Yep. Yeah. Go ahead.
Okay, I know we are anxious for time. In terms of the panelists that are here to share their insights, I'm gonna just be listening in for and would like some a better understanding of, because we're talking about medical insurance and things that, may be outside of our preview. I'm curious to making sure that the folks that are here to speak will help us understand the levers that we on the council and the city has to be able to help support the vision of Councilor Anderson, just to make sure that we are able to laser in on the things that we do have some control over. But I really do think that there is a pathway towards that, and I'm really excited about the conversation. Having dealt with my own mental health issues as a young person, this is a conversation that is near and dear to me, so I really do appreciate the sponsor for bringing it to the floor. Thank you.
Thank you, Councilor Mejia. So again, with that, if we can, I'd like to now introduce today's panelists testifying on behalf of the administration. I believe we are supposed to have Dr. Ojukutu, but there may be somebody else from Public Health Commission in replace of her. And this is on the first panel, and Andrea Amador, the Senior Director of the Boston Public Schools Behavioral Health Services. So if the representative from Boston Public Health Commission and Andrea from Boston Public Schools, if they have anything to present, now would be the time. And we do have a second panel with Jessica LaRochelle, Kelly Harrington, and Steph DeNormand after this. So we'll do a round of questions on second panel. But Kevin, are you in place for Andrea?
No, I guess I'm replacing Dr. Ojukutu.
Okay. All right. Great. Appreciate that. Kevin, why don't you thank you, Dr. Simon, for being here today. Why don't you start us off with the panel discussion, please, and thank you.
Got it. Thank you. Thank you, Mr. Fitzgerald. Good morning. So my name is Dr. Kevin Simon, and I serve as the Chief Behavioral Health Officer for the Boston Public Health Commission in the City of Boston. Thank you to Councilor Fernandez Anderson for filing an order on this important issue, and Councilor Fitzgerald for chairing the hearing. At the Boston Public Health Commission, we understand that youth mental health is in a crisis. Appreciate Councilor Anderson referencing our mental health report. And we urgently need to support youth with a full spectrum of accessible mental health services. Now, as a practicing child and adolescent psychiatrist, I am deeply involved in the lives of young people and families, particularly those with system involvement, including Department of Youth Services, Department of Child and Family Services, Department of Mental Health, who urgently need mental health support. My work allows me to actively engage with them, providing firsthand perspective on the challenges they face. And in recent years, it has become increasingly clear that our youth are under strain. This is borne out by the data, some of which was already referenced, but I'll reference it again. In March of this year, we released a report detailing the mental health status of Bostonians. Currently, more than 40% of BPS students say they're feeling sad, hopeless, or anxious. That's not to say that they have depression, anxiety, or suicidality. These are symptoms. This is consistently and significantly higher than a near decade ago, back in 2015, where just about 27% of those youth at the time described feeling that way. And even as they struggle, unfortunately, less than half of youth in the country, but even here in Boston, receive adequate support and services. And so this is a significant gap that must be closed. And now to help close that gap, earlier this year, the City of Boston and Boston Public Health Commission announced a historic $21 million investment in services for youth and family mental health. There are three efforts in particular that I'd like to highlight that are relevant to today's discussion. We are working in close collaboration with BPS on an innovative pilot program with 10 schools to promote trauma-informed school system transformation. We'll collaboratively examine BPS policies and systems of care practices to strategize better, more equitable healing systems and safe spaces for students, families, and staff. Last year, we released an RFP for vendors who will work with school staff and students to design practices and policies that more effectively address and provide support for the trauma experiences that our students and vicarious trauma that our dedicated city staff face on a daily basis. Second, we're working to provide behavioral health training for community-based organizations that serve youth of color in Boston. From our data, we know that people who work with Boston youth are likely to be confronted with the mental and behavioral health needs of those youth daily, but may feel unequipped to help. We are seeking to provide these youth-serving organizations who already work diligently to provide access to meaningful, enriching activities, the means to support youth behavioral health more directly. We are currently hiring a vendor who can provide innovative training and tools for adults currently working with youth to aid in early identification of youth behavioral health issues, promote effective community-level behavioral health intervention strategies, and provide clear pathways for adults to guide youth to access Boston's youth behavioral health services. And then finally, as part of our work to destigmatize mental health, we are launching the Heads Up Boston awareness campaign. The goal here is to emphasize mental health as a public health issue and make it easier for youth to tell someone they need support. We want to equip youth to talk about mental health, support one another, and know when to reach out to a trusted adult for help. For all of these 3 initiatives, trauma-informed schools, behavioral health training for youth-serving organizations, and the awareness campaign, youth do not need a diagnosis or a formal diagnosis to benefit. So, like the spirit of this hearing, these initiatives are intended to have a preventative effect, helping to prevent at-risk youth from developing a clinical diagnosis. Overall, these efforts are aimed at enhancing our capacity to provide long-term, effective, supportive support for our students. In addition to the initiatives that I just referenced, I have to describe that the Boston Public Health Commission is committed to sustaining our direct mental health services to young people. BPHC has school-based health centers at 8 BPS high schools, including the Burke, Madison, Boston Latin, Brighton High, Boston Community Academy, New Mission, Snowden International, and another course to college. Along with other medical services, these health centers also include a mental health clinician, and any BPS enrolled student may seek counseling or therapy, and all services are completely free to the student and their family. As part of their care, each student is given a preliminary diagnosis, which again is the concern here in the hearing. We find that most students carry some form of depression, anxiety, and or trauma exposure. It's important to highlight the importance of preventative services as they are designed to prevent at-risk youth from developing clinical diagnoses. So we also have Healthy Baby, Healthy Start, and Father Friendly Initiative offer services that promote positive relationships between children and their parents, which could hinder the onset of adverse behavioral health outcomes. The Early Childhood Mental Health Program offers early intervention and services to address families in the child welfare system. We work to ensure the workforce providing the preventative and treatment services utilize trauma-informed equitable approaches through the capacity building and training initiative that we have through the Commission. And in closing, I'd like to just say that I'm excited about the progress we've made and the path that still lies ahead. And to note in reference to the counselor's comment about diagnoses, and this is where the training will be very helpful, a diagnosis, particularly for those who are youth, is not a static situation in so much as over time, as was noted, diagnoses may change, circumstances may change, and the well-trained individual that might be providing the diagnosis should be highlighting, does the person still meet, quote unquote, the full criteria for the respective diagnosis? And or has there been some, what we would say, partial remission? Meaning they don't meet all of the entire criteria, but there's still some symptoms. Or have they met full remission? I.e. they used to meet criteria for major depressive disorder, or attention deficit hyperactivity disorder, or ODD. There's really over 200 diagnoses in the DSM. if they no longer meet those criteria, but they're still engaging in the care, you still can document that the person previously had X condition, but now they've met full remission. And in reference to state and federal policy, we have protections, or we're supposed to have protections that limit accessibility of non-providers to knowing what students or young people or even adults have in terms of diagnosis. And so I should highlight, HIPAA with regards to the Patient Protection Act, and then Counselor Burden, I believe, referenced substance use disorder. In our state and other states particularly, there is the confidentiality of substance use disorder patient records, 42 CFR Part 2. I'm particularly aware of this in part, my clinic, all the patients that I engage have a mental health condition and a substance use condition. And there's an added layer of protection when persons have quote unquote dual diagnoses in reference to who's supposed to be able to access that information. So I look forward to hearing the other panelists and being part of this conversation, and appreciate the counselors for having this opportunity. So thank you for sharing the time with me.
Thank you, Dr. Simon, and for all the work you do every day in helping our youth. We really appreciate it. So thank you for keeping this effort going. I'll open it up to, that's the first panel, so I'll open it up to questions. I don't think anyone else has joined at this point, so I think we can go right to our sponsor, and Councilor Fernandez-Anderson, we'll give you 5 minutes at first, and we can go for, if there's follow-up questions, we can do that afterwards. The floor is yours.
Thank you. Thank you so much, Mr. Chair, and thank you, Dr. Simon. Really appreciate you being here in this conversation. My questions specifically are I have other questions, I have 1,000 questions, but specifically to the things that you mentioned, alluded to, the program, with the father-friendly as well as Healthy Child, Healthy Baby. And in terms of capacity building, do you have numbers of how many people you're supporting, and with the new initiative that you spoke of in terms of like not needing a diagnosis, when would that be go into play? And you mentioned some schools that it sounds like you'll be piloting this thing. So I'm really excited to hear that. And in terms of capacity as well, like what do you foresee, or how many people do you foresee serving? And then with the father friendly, I know that their scope of work includes like group therapy and some supportive therapeutic services to fathers as a preventative measure. Obviously, if you have stable families, then you have stable homes. But specifically, it does not connect to this topic today. But I wanted to know if there were any other services that they are providing that I missed.
Yeah. So in reference to the numbers as it pertains to the Healthy Baby, Healthy Start, and the Father Friendly, as to have my team provide you with the exact numbers in reference to like fiscal year 24, that we can get you. And then I think you wanted to know the names of the schools for the new initiative.
No, I thanked you for giving me the name of the schools, because it included my alma mater, and I was just like, that's great. But in terms of capacity as well, like how many youth do you foresee in the age group? And they sound like high schools, but how many people you foresee serving as well?
Yeah. So in reference to the 8 schools that I referenced, those schools are the ones that BPHC has school-based health centers in. And so I can have the director of the school-based health centers provide you with the total number of students that they've served last year. And then in reference to upcoming school year, so I guess to start in September 2024, there'll be 10 other schools, and I just want to list the 10. So the Ellis, King Elementary, Richard J. Murphy, Young Achievers, Joseph Lee, William Henderson, Tech Boston, the McCormick Pilot School, Excel, and then Madison. Those schools are involved in the trauma-informed school system transformation. And
this includes the pre-diagnosis types of services, the temporary
Correct.
That's awesome. Could you send me a list by email? Could you send us a list through the chair, please? A list with capacity in terms of like, if it's one clinician, how many students would you say that they're seeing? And the importance there is that the concern, and you know this, Dr. Simon, you're the expert, that in terms of, whether they're using cans or comp, they are rushing through the process because they're so over capacity, then obviously diluting the quality of work. And just I'm really interested in understanding as well, like the homeschool connection, right? If you know this, that no treatment is efficient unless there is parent buy-in. To be able to, like, all your charts that you can throw at them to monitor at home is not going to work. Nothing is measurable because at the end of the week or twice a week when you see this kid, what is being monitored? Does the parent understand the diagnosis? Are they being educated? Is there a homeschool connection? And how are we educating parents to follow up with that?
Yeah, so what I'll do is I'll have our team, again, directly, I guess, provide the list to Counselor Fitzgerald, who will get it to you. And then also describe what specifically the trauma-informed school transformation is, so that way the counselors are aware. And again, I agree entirely in reference to sometimes the expeditious nature that clinicians attempt to get through forms and get through screeners. I can say clinically, particularly when you're talking about immigrant families, English second language or English third language. Generally, in child and adolescent, you're supposed to have diagnoses that are made over time. In part, you got to talk to the youth. You should talk to the parent. You should get collateral from any school-involved person, or if there are individuals that care about their person. So we fully understand.
You see the concern with home-based services before you can actually give a proper diagnosis, as you're saying, over time, how do you explore all of the domains before you can say, like, okay, we went to community, we went to church, we went to school, we went home, and then now we've created a comprehensive treatment plan because it's holistic and it's wraparound. It's not wraparound if we're not doing that. And so we keep turning to, using these terms, and when you hear wraparound, everybody's like, yeah, everybody's excited, but it's like, well, yeah, it's an amazing concept. It's trauma informed. It does it would do all the amazing things if it's being implemented correctly. So I think I'm interested in quality control, and I know that's probably my time. I'm just off the top of my head, Mr. Chair.
Yeah, I mean, you're right on it. I'll give you one more minute.
Thank you so much. So just, sorry, Dr. Simon, I kind of interjected there just to plug in that piece in terms of making it holistic, as you said, like how are we connecting with parents so that we can explore the different domains before we can reach a diagnosis?
Yeah, and again, this is in part where our public mental health campaign will be important. And then also talking about the systems that aren't present here, including all of the alphabet soup of DCF, DYS, DMH, who all have responsibility to help our most at need families. So again, I appreciate having the opportunity to be here, and I'm sure I'm over time, so I'll just stop.
I do appreciate, just wrapping up, Mr. Chair, I do appreciate you bringing that up. BPS don't know their reason, so we're going to give them grace why they didn't, they canceled last minute yesterday. But Mr. Chair, if time allows in the future, would love to continue this conversation in a more holistic way with the organizations that Dr. Simon has mentioned, because this conversation can't be had in a silo with Boston Public Health Commission and expect, Boston Public Health Commission to fix it, right? So we do have to expand it and make it more holistic. Thank you so much for your time, and thank you, Dr. Simon.
No, understood. And thank you, Council Fernandez, for those other thoughts as well, because you're absolutely right. And it's a complicated, I'm learning a lot just listening. And Dr. Simon, you're never over time. You're the expert. We're here to listen to you, and very much appreciate you being here as well. Council Braden, you're on the clock.
Thank you, Mr. Chair. Thank you, Dr. Simon, for being here. You mentioned, I think, one issue that I'm aware of, and it goes back a long time. It's like different cultures have a lot of stigma associated with mental health issues. I don't know how we address that. Like, I think it ties into a lot of that home to school connection and a lot of education, but how do you address that, and what's your perception of the I think things have changed a lot, but I think we have a long way to go in terms of stigma against the whole concept of mental health needs.
Yeah, no, so Councilor Redden, I appreciate your question in reference to thinking about cultural considerations, familial considerations in terms of mental health. And I think this is where, as a practicing psychiatrist who engages with a lot of families of many different ethnic backgrounds, I think part of it is recognizing that when a family has an opportunity to be with me and my team, knowing that we're going to provide education to the parents, meaning if a parent wants to have a conversation about diagnoses, they can have that. If a parent wants to talk about parent guidance suggestions in terms of should we put restrictions on their cell phone use or finances, we'll have conversations about that. And then in terms of sometimes if medication is needed, it should be afforded to parents an opportunity to, and to young people, to ask as many questions as they want in reference to understanding what is it that this is supposed to do for me. And so I'm sure everyone here has heard about the phrase placebo, right? Things can work even if you don't realize that you're just taking a sugar pill. Interesting enough, there's something called nocebo, which is to say that if I don't tell you the risk related to not doing something or the risk related to side effects that could occur, and you, let's say, take a medication and you have a bad outcome, you're more likely not to ever take that medication again, which may result in persistence of, let's say, the negative thing that we're trying to address. So a lot of information has to happen, and that information can't possibly be digested in just 30 minutes or just in 60 minutes. And so for the families that I've had, whether they're from Hyde Park, whether they're in Rosendale, whether they're in East Boston, we take time in our clinic to be there and be available. Before our session today, a young person who's system involved called to say, hey, I don't want to come in today. It's like, well, our appointment's at 2 o'clock, but it's 9 o'clock. Why don't you want to come in? It's like, well, I've been thinking about a lot of things. I say, okay, well, I can come to you. And so sometimes teams should be flexible in terms of what is possible, because engagement in care is the most important thing. And during that engagement, we can figure out whether you have a misperception, whether you have doubts about a medication, whether you have doubts about therapy. The engagement part is important. I think Councilor Fernandez, Councilor Mejia described different aspects of mental health experiences that they've had. And I would suspect most of us would recognize when we're engaged in care, and I'm just gonna say care broadly, be that a coach, be that a mentor, that's what you want. And so for the young people that we're describing that are feeling sad, feeling depressed, feeling anxious, the real concerning part is the fact that they say they don't seek any kind of intervention or any kind of adult. So we're trying to train teachers, train staff, train coaches, nonprofit organizations. I know for sure in terms of, again, the preventative nature, we have to be fully recognizing that not all intervention has to be medicalized, right? So organizations that we've worked with, Beat the Odds, they were presenting within our youth mental health summits. We had 3 summits, one for parents, one for youth, one for providers, back in April and May. Boston After School and Beyond, Center for Teen Empowerment, the St. Stephen's Youth Program, like the Youth Connect, these are a lot of organizations that work with young people, work with families, because we realize that care does not only happen inside the walls of a clinic or inside the walls of a hospital. So we're really trying to partner with community organizations.
Thank you. I agree that the therapeutic effects are well beyond the clinic setting. I wanted to get your thoughts on perhaps, I know there's a conversation about limiting cell phone use in schools at the moment. I feel that, I think our young people are under incredible stress, anxiety producing media that's bombarding them 24/7. I don't know what your thoughts are on we have to use every tool in the box, and I think reducing that negative stimulus. I don't know what your thoughts are on that.
Yeah, no, again, you're bringing up good points here. So the current Surgeon General, Vivek Murthy, put out a report on the kind of impact that social media can have, and just social media and not to say internet sources can have on young people. And we'd say it's like a catch-22, in so much as there are niche groups that actually find connection in a subgroup that exists on a social media platform, right? And so we highlighted that there are higher rates for suicidality, higher rates for anxiety, depression in our trans youth, in our LGBTQ youth. Sometimes it's that group that they find online that is able to kind of service as an outlet, because otherwise in their home or in their native environment, they can't. So there is some potential for good in social media. Simultaneously, there is potential for bad, in so much as, a fraction of a second of a post, of a picture, is just a fraction of a second, but a young person whose brain is not fully developed might think, why don't I have these things that, other people are posting about? And that's a topic of conversation that I have pretty regularly in some of my therapy sessions, in terms of young people looking at others and looking at what they don't have in comparison to others, not recognizing, that's just a photo or a short 30-second reel. That does not necessarily mean the person who's posting, that's the entirety of their life. So again, that understanding of the good and potential harm as it relates to social media use, that can come from, again, kind of courses, classes that exist within some of our school curricula, what's healthy to do. There have been different organizations and different institutions that have, like I have a little bucket here. If you come into class, put your phone there. That doesn't mean that you can't hear it if it notifies in case there is an emergency, but having it on your person while you're in class can be distracting. So those are a variety of initiatives that are being done in different school districts around the country.
Very good. Thank you. I'm sure I'm past my time, but thank you so much.
Thank you, Councilor. Councilor Worrell, you're up next if you're here, and so the floor is yours, sir.
Thank you, Chair, and thank you to Dr. Simon for being here. This has been very informative. I'm learning a whole lot. One thing that I'm very intrigued about and would like to hear more about is you working with external partners that are working with our young people. Now you're training them to help with the care network or being somewhat of a care provider. Can you elaborate on plans and how you envision this scaling up, or the investment that the city is putting forward into this type of training?
Yeah. So thank you, Councilor Worrell. In terms of I'll speak to the collaborative nature of like academic institutions, nonprofits that exist, the city. So back in the fall of 22, you might have heard about like a youth safety task force being formed as it relates to young people that are at most acute risk and potentially have demonstrated willingness to engage in certain kinds of activities. But part of that task force is engagement with nonprofits. Again, sometimes I could name some. The sum that I name is not the entirety of the list. But what we'll do is if we identify a young person in the family that might be helped by a service that we know exists, but it's hard to know all 100 organizations. we'll get them connected. So I know for sure a couple of weeks ago, I saw Councilor Braden in Austin as a celebration as it relates to Bridge Over Troubled Water, which is for young people who are unhoused. If we realize during one of our meetings that that's a situation that a family or a young person is going through, well, we know now how to connect that person to, for instance, Bridge Over Troubled Water. If a young person needs to be connected to therapeutic services as it relates to they were involved potentially in a situation that results in our Boston Police Department colleagues engaging with that young person. We have an organization, or the city has an organization called Youth Connect, which intentionally works with officers to try to mitigate having young people go in that direction. And so our connection and collaboration that we have, it's trying to better assess what services is needed, because when Councilor Anderson highlighted, mental health is not really just one thing, right? So someone's housing could cause them to have a mental health crisis, somebody's food security, unemployment, yes, the school environment, yes, their peers, are they engaging in substance use? So there's a whole host of factors that go into somebody potentially having a poor or positive mental health outcome. And so part of our office and part of the commission's role is recognizing, wait a minute, mental health is not only improved by just therapeutic service. And sometimes it's the relationship that the young person or the family will have with somebody who is not a clinician at all. And so, I can highlight, again, it would seem atypical, but this is the kind of innovative thing that we're looking at. The Boston Housing Authority put out a RFP in reference to the theme Credible Messenger. And so Credible Messenger is a platform where people who have had certain kinds of history that results in them being incarcerated, but have now, they're no longer incarcerated, and they don't want other young people to go in that direction. They're the credible messenger, because there's certain people that in the community, if I show up, oh, you're Dr. Simon, you're gonna tell me what the doctors say. The credible messenger is somebody that has the background and has the relationship and understands the nuances of the community. And so BHA formed a credible messenger RFP, and we were a part of helping think about, okay, who's the actual organizations that would be a part of this, who really would have credible messengers, who could speak to our young people that are at greatest risk. Because it's not going to be necessarily the licensed clinical social worker or the psychiatrist that is going to be the credible messenger for certain communities and for certain young people. So I'm giving you a long answer. In part, there's a lot of different relationships that are happening, because we recognize that behavioral and mental health is really impacted by many different forms of outcomes or forms of externalities is what we would call them. And so the relationships, it's multifaceted. I know some counselors have reached out, because a constituent has reached out to them to say, hey, something's happening here. And we're trying to connect to make sure that we're best serving our constituents as possible.
Thank you for that. And I'm super excited about the Credible Messenger program that's going to be happening in Franklin Field. I think it's teen empowerment that's servicing the neighborhood. And it's great to hear that you're part of those conversations, and looking forward to seeing the outcomes and the impact that's going to have on our neighborhood. No further questions. I'm going to be enjoying the rest of this conversation, and looking forward to continuing to learn, but also to Councilor Fernandez-Anderson's earlier point, we'll love to see how this thing is also implemented, and the actual manpower or the people power that you have behind this as we're talking about BPS and actually servicing people. So thank you, Dr. Simon. We'll just be listening to the rest of the conversation.
Thank you.
Thank you, Councilor. Councilor Mejia, you're up next. The floor is yours.
Thank you, Chair, and thank you again, Dr. Simon. Happy to see you, and grateful to the sponsor for her intentionality regarding this conversation. I think it's really strategic and smart to have it now so that we can start really thinking about the things that we're going to be advocating for in the future as it relates to both the BPS and the budget. So kudos, we're getting ahead of it. Yes, and I love to see it. So, Dr. Simon, you know, my office has been working in deep partnership with you over the last few years. We worked with young people, with Dr. Crump Swaby, and created a youth mental health ambassadors program. And we piloted first citywide, and then we lasered in at the Burke because of, you know, a lot of the violence that was happening there. And we felt like this could be a workforce development initiative. And those young people actually, you know, in their genius, under Dr. Crump-Swaby's leadership, created a day of self-care. This was the second annual event. And as we're thinking about credible messengers and the people who are really on the front lines, I think that, to Councillor Anderson's point, in terms of really identifying as many different pathways where young people are being able to connect to services or extracurricular activities that help them deal with the trauma that they're focusing on. I think that, you know, the work that the Burke has done over the last 2 years now, we're in our second year in piloting mode. We would really love to see that concept. And I think that that's what you all are doing with teen empowerment, right? Is like really expanding young people in that capacity. Is that what, when you're talking about credible messengers, is that the work that they'll be doing in schools or just communities? If you could just provide some clarity around that.
Yeah. So one, appreciate you being here. In reference to Councilor Rowell, he highlighted that in the Franklin Field area, Teen Empowerment will be having some of their staff working with certain young people who, again, have been identified as being at greatest risk, potentially for outcomes that no loved person, guardian would want for their young person. And so that will be specific to the Franklin Field area. In reference to the Burke and the Mental Wellness Day that was had last year, I was there. I enjoyed hearing the young people. Some were doing hair. Some of us shot horse on the basketball court. And I think Burke, in that way, served as a model for other schools that, you know, one day out of the school calendar year is not many days. And yet it can serve as a real buoy for a lot of young people who are coming to school. You got to think about it, they spend 6 to 8 hours in school. And it becomes a space in which a lot of release happens. And so sometimes the frustration, or, you know, Councilor Anderson, you referenced ODB. Sometimes the oppositionality is not really about oppositionality, right? The oppositionality is you happen to be the person that is asking me just yet again to do something when I have to take care of my younger siblings and I don't get a thank you for that, right? And I have seen young people who have been truly suicidal on our inpatient unit. And when I'm engaging with them, what I'm hearing is much like an adult would, like exhaustion. Exhaustion from the kind of circumstances that they're in, exhaustion from really having to support sometimes their family because their parent is supporting them by working 2 or 3 jobs. And so what the Burke did in terms of last year, just having that day where, hey, you can just come, just be yourself. We're not going to pressure you with regards to the academic efforts, actually probably buoys people to want to come back to school. And, you know, I think you all even, or not you, but the Burke even highlighted the students that had really high attendance rates, right? Because sometimes those are things that signals and positive feedback that they don't get. I'm like, I see your hand up.
Yeah, no, only just because they only give us 5 minutes, so I gotta get as much as I can. So, yes, and so this was our second year in the pilot, and last year we did it and Superintendent Skipper attended. And so our goal is to implement this across the entire district, that one day of wellness, and not just for the students, but the day during the day would be for the students, and then in the evenings it would be for the the whole family, like, because I think wellness needs to be wrapped around, and we have to start getting into the habit of creating spaces. And I think that this would be a really good pathway towards that. And then the other piece of the puzzle in terms of really looking at other pathways is that, you spend 45 minutes to an hour sitting in the barbershop or at the hair salon. And we piloted a program specifically where we trained, Dr. Crump Swaby trained hairstylists and barbers on mental health triggers. And the whole idea is that once you're getting your hair done, you were getting your head fixed. But I think as we continue to roll things out, I think this is an opportunity to Counselor Anderson's, vision around this, is that perhaps even if it's just a gift certificate to a barbershop or a hair salon, and they have a 45-minute session, and we could target some of the barbershops and hair salons in the neighborhoods that would be willing to enter into some sort of pilot, because we already have these folks trained and ready to go. It would be great to, if there's other ways for us to have targeted, even they could be the ones that do the referrals. They don't have to be the ones doing the treatment. Right. But if there are ways for us to leverage the outside community as credible messengers that will help support and connect young people to the support services that they need, that could also be part of the strategy when we're thinking about who are all the people in community that can help support the social, emotional, and mental well-being of a child. So now we're looking at it from the school perspective, but we're also looking at who are the people in community that we can foster relationships with, and they could be an added layer, so that we're looking at this from an inside and outside. And I think community in the barbershops and the hair salons is such a breeding ground for mental health and wellness conversations to happen. And I think maybe this is not specific to what the hearing order is about, but I think that there is a path and a role for external partners, to Councilor Morell's point, to play in helping to support that child in and out of school. So I'd like to offer that for consideration.
Yeah, no, so I appreciate, and I fully recognize that. I appreciate the comment in part. In other medical spaces, particularly hypertension and diabetes care, there have been efforts, particularly with barbershops and beauty salons, about having kind of like what we call community health workers in those spaces. Because if you think about it, some people go to their barbershop at least once a month. Some people even go more frequently, which in theory would be the kind of cadence you would want for like a therapeutic engagement. So it doesn't necessarily have to be that the barber is the person that is relaying the information. It could be that because I go to a barber, and there simultaneously, and then we're paying potentially for that young person or adult to get their haircut. And so, oh wait, you're paying for my haircut? I'm willing to listen to this information. Oh, and you're sharing information, and I look racially and ethnically concordant with the people that are there. The evidence demonstrates that in the hypertension and diabetes care space, there have been trials of this exact model, and people are actually far more receptive in following the recommendations of the provider that looks like them, who met them in that space.
Well, thank you. And I'll just end with, nobody here is the expert, and I think that oftentimes we walk into spaces and everybody thinks they know it all. I am not one of those, and so I'm just offering things that we've tried to figure out just to meet the moment. And so, whatever we can do to be supportive, I'm here for it. Thank you.
Thank you all, Councilor. And I know Councilor Tanya Fernandez, it seems like she wants to have a rebuttal to some of those things said, but let's get to Councilor Coletta Zapata first. I'll give you one last crack at the end before we move to the next panel. How's that? Councilor Coletta Zapata, the floor is yours.
Thank you, Chair. And I have been listening in intently to the conversation. I just have to say to Dr. Simon, I am so impressed by you and deeply admire your expertise and just the level of understanding that you have of this crisis. And it is a crisis. We all know that the suicide rate is up. I think it jumped to 40% in the last 20 years. And emergency room visits, I saw a statistic that it went up to 88% of self-harm for teenagers. And there's so many reasons for this, of course, but really, what is the city doing to mitigate this crisis, to help these kids and make sure that they have the resources that they need? And clearly, we are doing a lot, and really, it's under your leadership. So I just want to thank you for that. My question with partnerships was asked by Councilor Worrell, and then wanted to double down on the relationship with BPS, and I feel like that's already been kind of said. But I guess resources for families when there is an adolescent that's struggling with anxiety or depression, or they have a very impactful life event. I guess, what is the city providing for families? What resources are we providing for families to identify some of this behavior? And I guess, what are we offering as support and strategies for any child that's coping with fear or hopelessness, or understanding some of the events, the world events that are taking place, hate crimes, terrorism, war, other tragedies? Like, what are we providing for families and our kids as a city? Thank you.
Yeah, no, thank you, and thank you for the comment. In reference to things that we're providing, so one of the challenges tends to be people knowing where to go. Because again, there are services, but if you don't know where to go, then it doesn't even matter that it exists. So right now, if any person were to kind of type in on their computer, behavioral health crisis service in Boston Public Health Commission, we have, I think it's 12 languages. 12 languages where we detail in Haitian Creole and Russian and Chinese and Muslim Arabic, obviously in English, Spanish, who you would call in what specific kind of circumstance. Yes, most people, because this number has existed for a very, very long time, are going to call 911. It doesn't mean that you can only call 911. It happens to be that there's also 988. It happens to also be that our state happens to have a behavioral health helpline, 833-773-2445. And if you call that helpline and you describe the circumstances, be it a young person struggling with anxiety or suicidality, you'll get connected to a clinician that will connect you to the closest community behavioral health center. For Councilor Gabriella, right, someone might get connected to Neighborhood Health, or formerly East Boston Health Center. If you're in the Roxbury area, perhaps you get connected, it depends regionally. You might get connected to BMC, you might get connected to Whittier Street. If you call the behavioral health helpline that the state has put in, families will get connected to the right set of service at the right time. Because the goal is to have the right service at the right time for the right need. And sometimes if the circumstance, and I see this often when I'm on call, a family will come to the emergency room, but then when they describe what exactly the situation is, say, oh, well, this isn't a mental health emergency, but it sounds like you don't have resources in the home. And so we'll connect them, for instance, to something like youth villages, which has therapists, clinicians, therapeutic mentors that go to the family. So in terms of the city's role, we are trying to serve as that connector. And so we have regularly received the 311 or regularly received emails from the different counselors here as to connecting families to the right resource. Because if you have a pediatrician, and here's the service, if you have a pediatrician and you want your child to get a mental health evaluation, because you know that they have, for instance, autism spectrum disorder. This was diagnosed when they were 2 years old, but for whatever reason, services haven't been connected. Every pediatric office that exists in the city, let alone the state, has access to the Massachusetts Child Psychiatry Access Project, MCPAP. But if a family does not know, I should go to my pediatrician and say, hey, can I get a MCPAP evaluation? It might as well be that MCPAP doesn't exist. So I had a conversation yesterday with a mom to say, oh, you want a MCPAP evaluation. Here's the email, here's the name of what I'm telling you. When you go to that pediatrician, they're supposed to connect you. Because if you do have insurance, which there's still is a percentage of individuals that don't have insurance, but for the majority that do, either through their employer or through the state. There are services that you can get, but oftentimes it's that linkage and really that gap of information then creates the actual gap of care. So as a city, we're trying to enable our constituents to be aware of what resources they have and what levers that they as a constituent should be able to tap into, whether that's coming from the school, whether that's coming from the pediatric office, whether that is that they don't have anything and they're going to call in crisis. We're trying to do that connection in real time.
Thank you. Thank you for that answer. And you did remind me that in East Boston, thanks to the former East Boston Neighborhood Health Center, now NeighborWorks, we have, instead of just a regular emergency room, we have a behavioral health urgent care, which I think it does help with the stigma. And many folks in my community and children of immigrants have said, you know, I never thought to tell my parents who are working so hard just to survive that my mental health is really spiraling. And, you know, to go to the emergency room or to go to the hospital was quote unquote dramatic. That was an actual term that's been used to me by somebody who is a second generation East Boston resident. And so this behavioral health urgent care service really shows and demonstrates that we care about this, that yes, you can come in. And I obviously would love to understand through the conversation here about insurance and all of that, how we can make that accessible to everybody, but just really grateful that East Boston has this resource. It took many hands and many years and state funding allocation. Do you foresee that something like this could be replicated elsewhere in the city? And I'll end my questioning there. And I guess what are the barriers to getting this behavioral health urgent care service in all neighborhood health centers? Thank you.
Yeah. So one, great question. Two, I gotta fully recognize where my role stops and ends. In terms of the state funding, and to your point, our representative who chaired that committee, highly involved. This is a larger conversation, again, than just me and my role at BPHC. But I think in terms of the funding support, I think the state fully recognizes that mental health is, a crisis. Our boarding numbers, or when I say boarding, meaning individuals who meet a higher level of care need, but then there is not a bed available for that said person, that number is actually slowly going down. And that data comes from the Massachusetts Health and Hospital Association that tracks it weekly. In terms of the resource allocation for like a behavioral health urgent care, I think that is something that the state is actively thinking about. I know the state is actively also thinking about what we call ED, or emergency department diversion services, such that if people do come to the emergency department, but we recognize again, wait a minute, I don't think you actually need to be here right now. Here's a program, here's a connection. That is something that I know the state had put out 2 years ago and is implemented in a couple of the local hospitals. So I am very positively optimistic that further funding will continue, because again, the crisis is seemingly not waning.
Thank you. Thank you so much for that answer. Thank you for everything you do, to the chair, to the lead sponsor. This is a fascinating conversation. And to Councilor Mejia's point, a lot to learn, but this was an informative so far conversation. Thank you.
Thank you, Councilor Clettis. I just have a quick question before Councilor Fernandez. I'll let you just sort of do a very short conclusion at the end here with Dr. Simon. But I did my maiden speech on the trauma response team, and typically that is in response to, homicides, violent activity, things like that, and going out and working with the families involved. But I always envisioned the trauma response team being greater than that and responding to more than just shootings, if you will, but also to bullying, to, domestic abuse, and to other things that sort of cause the nature of the youth to feel this way that we're talking about, right? Is there a correlation between what you do and the trauma response team, and how to sort of meld the two together to be more encompassing, I guess, right? Because everything is sort of related in that way. Or is that just sort of part of, we want to understand why you're feeling this way? Oh, you witnessed something that was horrific to witness, and let's work with you on, your suicidal thoughts, your sadness, your trauma, or is it? Are those different avenues? And again, just a brief answer, but
Yeah.
well, I had you here. Yeah, thank you, sir.
Yeah, so I appreciate your question. In reference to the Neighborhood Trauma Network or the trauma team, they are, well, a facet of it is also located within the Boston Public Health Commission, and it is a network of regional or city located trauma teams. They are specific to responding to certain firearm violence. In part, firearm incident in real time is very, very, very different than a different type of incident. So we do collaborate in terms of what the response looks like. Because then also there's the firearm episode at, on like today's Thursday, firearm episode today. That's going to have ramifications. It already had ramifications before, but it's going to have ramifications for a long period afterwards. And so that's where partnering with organizations like the Lewis D. Brown Institute is important. So we do collaborate, but I would afford the leadership of the trauma network to speak more on their specific scope of work and how they could potentially be expanded. But I would say that resource allocation for what they do is important.
Yeah, I think my point is always for the trauma network, how do you expand it to the work that you're talking about, right? Wouldn't it be great if a kid who's bullied at school, just like you would show up to the shooting that night and work with the family and the neighbors that were involved in where the shooting occurred, if a response team could show up, whether it's in school or comes from outside, but shows up to the trauma that occurs, at a school, around a playground, at a youth spot, whatever it may be. Just a similar type service. It's an ideal, but just thought I'd mention it. But Councilor Tanya Fernandez-Hanson, please just a quick 2 minutes, because I know that you've heard a lot since you've spoke and probably have a couple other thoughts on it. So floor is yours.
Thank you, Mr. Chair. Dr. Simon, are you sticking around with the panelists that are going to speak next?
Yes.
Okay, great. Thank you. No, I heard a lot of good ideas, a lot of good points from my colleagues. Dr. Simon's been very thorough in answering. I think I did appreciate that, you sort of curved the ideas about the whole, communal space type of supportive services to say, providers or professionals have to be able to handle that. The concern obviously is like opening up a can of worms or peeling a Band-Aid and then letting it spill over, and then may lead to a crisis when they're left to deal with it on their own. And so it's important that there is a professional, and that leads to the whole crisis response teams, right? Because when there is a crisis and you deal with the crisis, there's de-escalation, but then there's the part about sustainability, and as you were saying, in terms of connecting them to wraparound services, the aftermath obviously can be even more long-term, more dangerous. And as we know, it takes about 2 years just to get over one trauma, just to heal from one. Imagine now, crisis on top of traumas, on top of multiple traumas. And our kids experience at least 5 traumas by the age of 10. So when you have a crisis like that added on to it. And to Councilor Fitzgerald's point, I would say, in terms of crisis response, there are life coaches and other types of crisis response teams that does this, where they can actually come in and do more long-term therapeutic services, teaching the youth or families how to actually crisis manage, which is not just the immediate response. And so there are services in different ways. Some are life coaches, and some are actual behavior modification type of crisis response, when they're actually teaching kids to just especially youth that just deal with issues over and over and over and don't know how to problem solve. So there's different levels of care to it. I'm really interested in this conversation going toward understanding, again, the scope of work between the collaterals, crisis response team, the nonprofits, the different domains, schools, church, community, whatever, family, and connecting that to the parent, And last point I'll make is that, like Dr. Simon, we talked about an app idea in terms of enhancing the BPS app. You know how they're already tracking like progress reports and grades. That they should be more holistic to support families to, if you see a diagnosis on an app, like if the parent says, oh, there's my kid's diagnosis and this is the treatment plan, and teaches you, and it's interactive and it teaches you. And I know there are different apps that does different things, but consolidating with grade is more holistic. The parent can then monitor the kid's academic, mental health, medical appointments, and create some sort of incentivizing program where the kid can possibly connect a success link, and when you do volunteer work, the parent is monitoring, they can get paid for it, whatever it is. But these were some of the ways of sort of consolidating all of these like therapeutic treatments and charts and stuff that we give to parents, and then they go home, and then it may not get used, or parents still don't know what the diagnosis is. This is the same thing for IEPs, right? Like this is such a broad topic, and I understand that, and I'll stop here. And I really appreciate Councilor Mejia's ideas about, the barbershop. But again, in terms of like HIPAA and figuring out like, release forms and how we deal with that and what spills out in an environment like that, we do have to be very careful and thoughtful and look at how we can do that strategically so that it's actually appropriate, because it sounds like there's a whole lot of mess and trouble that can come out of that. Thank you, Mr. Chair. Looking forward to the next panelist.
Absolutely. Thank you, Councilor. We'll move right along then to the next panel testimony. And Dr. Simon, thank you so much for your time with us. Very informative, and appreciate you making the time of the day to educate us. I'd now like to introduce today's panelists for the second panel, testifying on behalf of the community. We have Jessica LaRochelle, the co-director of Public Policy and Government Relations at the Massachusetts Association for Mental Health. Thank you, Jessica. Kelly Harrington, our Senior Research Manager for Boston Indicators from the Boston Foundation. And Steph DeNormand, the Trans Health Program Manager at Fenway Health. So Jessica, Kelly, Steph, thank you so much, and thank you for waiting patiently as well. I hope you found the conversation to date informative and interesting and educating for your own selves, but we look to you now to educate us even further. And so I don't know if anyone has a presentation, but Jessica, we'll start with you for an introduction, and we'll move quickly through everybody else. But Jessica, the floor is yours. Thank you.
Wonderful. Thank you. Good morning, everybody. Chair Fitzgerald, honorable members of the Committee on Public Health, Homelessness, and Recovery. My name is Jessica LaRochelle. As the chair said, I'm the co-director for Public Policy and Government Relations at the Massachusetts Association for Mental Health. And I just wanted to thank you all for the opportunity to testify today on docket 0478, sponsored by Councilor Tanya Fernandez Anderson. So it's a pleasure to be with you all this morning, and really, really appreciate the council's attention to this very important issue. The Massachusetts Association for Mental Health is dedicated to the promotion of mental health and well-being while preventing behavioral health conditions and associated disability. We do policy advocacy work, we do knowledge dissemination work, we convene stakeholders across the behavioral health and public health sectors, and provide subject matter expertise. Related to this conversation, we're also a member of this Children's Mental Health Campaign, and we also hold 2 seats on the Executive Office of Health and Human Services, Community Behavioral Health Promotion and Prevention Commission. So a lot of the work that we do and our mission and the things that we care about are really relevant to the discussion today. There are an array of mental health supports and services available to children and adolescents with formal diagnosis, but there clearly is not enough capacity to meet the need. And this is so critical because half of all lifetime mental health conditions onset by mid-teens and 75% onset by mid-20s. And there's an 11-year median delay between the onset of symptoms and actually getting treatment. And youth with untreated mental health conditions are more likely to suffer from strained academic performance, absenteeism, suspensions, expulsions, higher dropout rates, substance use, and involvement in the juvenile justice system. So as a society, we're clearly missing autism symptoms early and connect youth and their families to evidence-based support and treatment. What I'd like to do is outline for you all some select low threshold prevention supports and services available to youth in the Boston area. And in presenting these, I hoped to support committee members in one, evaluating potential funding opportunities for mental health services, for expansion of such services, identifying opportunities for collaboration among stakeholders, and also just providing information so that you have this for connecting your constituents to resources in your communities. So I'm going to start off by outlining, as Dr. Kevin Simon was talking about, some resources, low threshold resources that do not require diagnosis for care outside the walls of a clinic or hospital. Then I'll talk about, I wanted to pick up on the theme of urgent care that Councilwoman Gabriela Coletta Zapata noted, in case youth do fall through their cracks, to make sure that folks are aware of urgent care and emergency resources that are available in Boston. And finally, I wanted to talk about a new innovation at Mass Health to pay 6 of preventive services, health services for youth without a diagnosis. Okay, so when starting, about community supports and interventions for youth without a diagnosis. So here's examples of some programs that have come across our desks that we have found have been pretty and effective.
Jess,
Yeah.
I don't mean to interrupt, but every so often you're just delaying. I don't know if it's we still hear your full sentences, but they're intermittent stops in between. I don't know if there's anything we do, but if you see people making faces, it's just us going, what? Wait, do we miss something? So we'll try and just keep going for now, because it really is so short that it's like not enough to say try and fix it. But I just want to, I think that's happening for everybody. So just wanted to make you aware that that was
okay.
We'll just continue on as if it's not. We'll go with it.
Okay. All right. I appreciate that. And maybe I'll pause in a minute or so, and if it's still happening, I will move. Okay. All right. So the first program I'd like to talk about is a program at Doc Wayne called the Chalk Talk program. So in 2019, Doc Wayne received a Children's Behavioral Health Innovation Award by the Mass Association for Mental Health, the Blue Cross Blue Shield of Massachusetts Foundation, and the Charles F. and Beatrice D. Adams Charitable Trust for filling an unmet need in the children's behavioral health system. What Chalk Talk does is it completely reimagines group therapy. And it does this through the lens of sports, team sports, such as soccer, basketball, and flag football. The coaches are actually trained clinicians, and they leverage sports and the game to teach youth about important life skills like teamwork and perseverance and resiliency and relationship building. Doc Wayne is based in Allston, but this is a mobile service, and sessions are provided on site at schools, in community centers, gyms, fields, or another comparable space. So it's just an excellent example of reaching youth outside of the walls of a clinic in an activity that is already engaging by trained coaches who are also behavioral health clinicians and teaching them important skills. The next program I wanted to share is, this is brand new, this hasn't started yet, is peer empowered support groups. So Mass Association for Mental Health is actually partnering with the Mazakowski Family Foundation to expand access in Massachusetts to peer empowered support groups for middle and high school age youth at Boys and Girls Clubs. The model is actually inspired by a promising program at St. Benedict's Preparatory School in Newark, New Jersey. And these peer empowered groups, they reinforce youth agency, resiliency, facilitate connections with other students, and just they provide a forum for listening and a place of support in a stigma-free environment. So we'll be partnering with 3 Boys and Girls Clubs across Massachusetts. And one of them is the Boys and Girls Club of Dorchester. And this peer support group at the Boys and Girls Club, will start in August, September of 2024. The next resource I wanted to share is Young Adult Access Centers. Again, these are for youth without a diagnosis. These are all operated and funded through the Department of Mental Health. You do not have to be a DMA client, you do not have to have a diagnosis. All services are free and all young adults are welcome. They're community spaces where youth and young adults go with mental health concerns, and they can access services and supports. It could be peer support, it could be social activities, linkages to resources like healthcare, education, employment, behavioral health supports, individual support to achieve their goals, and even amenities such as a shower, laundry, kitchen, and Wi-Fi access. There is one center in Boston that I wanted to make sure everybody is aware of, and that's at the Cherry on Dudley Street, 207 Dudley Street in Roxbury. Another resource that I wanted to share is Behavioral Health Helpline and 988, which are excellent. This is a complement to those two helplines. This started in March 2022, so it's brand new. It's called Hey Sam. It's a youth peer-to-peer text line, and it's operated by the Samaritans. And so it's for youth up to age 24. It's for youth that are feeling lonely, that are feeling depressed, overwhelmed, or having thoughts of suicide. All services are free and confidential. Youth text, and it's available anytime between the hours of 9 a.m. and 12 a.m. And they can get support from trained peers to help with crisis counseling and also just have somebody to connect with. Since it launched in March 22, already over 3,000 youth have used this services. So I think this is a fantastic low threshold resource for youth across the city of Boston to leverage. And finally, to pick up on Councilwoman Coletta Zapata's question about, there's an excellent website that's operated by the state called Handhold. It's Handhold Massachusetts, and it's specifically designed for parents and caregivers of children that they're worried that they're exhibiting some mental health signs and symptoms, and how can they get started, what to do, should they worry, and if so, should they reach out for help. So I strongly recommend that resource for families. So in picking up for students that and youth who fall through the cracks and aren't able to take advantage of these community resources because there aren't enough resources for all the youth that have needs, and who might end up needing emergent or urgent care. We touched a little bit about emergency care, Dr. Kevin Simon did, and the best thing to do is to call 988 or the behavioral health helpline at 833-773-2445. But I also wanted to reinforce the conversation about these new behavioral health urgent care centers. So that's a whole level of care in the behavioral health system that we didn't have before. Right? We have CVS urgent care centers on corners across cities and towns in Massachusetts, but we didn't have a behavioral health equivalent, and now we do. And so these aren't for somebody who is an emergency situation, like they're immediate risk of harm to themselves or others, but they are for youth and adults who may have recent changes in behavior or thoughts that are causing them distress. They might require some immediate support through evaluation or therapy. And these urgent care centers have extended evening and weekend hours. So we already talked about the one in East Boston at North Suffolk Community Services, but I also wanted to make everybody aware that there's two others in Boston Center, their Community Behavioral Health Center at 850 Harrison Avenue. And the other one is in Brighton, at the Brighton Austin Mental Health Association over on Warren Street. It's a program of the Italian Home for Children. So these are excellent resources, again, to help divert a young person from hospitalization or the emergency room, get them some immediate help, and then get them connected to longer-term resources. And the final thing that I wanted to mention in my oral testimony was that Mass Health recently, like this is since August 2021, released a bulletin that requires coverage for preventive behavioral health services for youth, ages 0 until 21. And by preventative, what they mean is that the youth can get preventive behavioral health services, up to 6 visits of these preventive behavioral health services. All they have to have is a positive behavioral health screen. They don't have to have a formal diagnosis. So it's not quite as much as low threshold as some of the services that I emphasize, like Doc Wayne or the Young Adult Access Center or Hey Sam, where you don't have to have a screen. It's completely low threshold. Anyone can just access these services for free and they're confidential. This is it's preventive services that are offered by a clinician. You do have to have a positive behavioral health screen, so it's a little bit higher threshold, but you don't require a diagnosis. And Mass Health will pay for these services in a primary care setting. They'll also pay for these services in school and community-based settings. They have to be delivered by a trained clinician, but if the clinician is based in a community setting, or if they're based in a school, they're reimbursed, for instance, for up to 6 groups. So I just wanted to make the committee aware of this because this has been underutilized to date, but I think it's a really important funding stream when we think about access and sustainability for these programs and trying to braid together as many different funding sources as possible. And in my written testimony, I will include a link to the bulletin with this new information from Mass Health. So thank you very much for the opportunity to testify this morning. I apologize for my spotty internet, but please don't hesitate to reach out to myself or MAMH if we can be a resource to the council on this work.
Jessica, thank you so much. And the beautiful thing was, even though it was everyone saw it spotty, you could still, it caught up with all the sentences, so we didn't miss a word, which is the most important part. And so thank you for that, and especially all the options and sort of their varying degrees of use and their strengths, and understanding how we can now use those as we come across those issues in our work. We'll move along to Kelly Harrington. Kelly, I believe you have a presentation, if I'm not mistaken, correct?
I
so
do,
please,
yeah.
The floor is yours. Thank you so much for being here.
Great, thank you so much. And I'll share my own screen. So my name is Kelly Harrington, and I am the Senior Research Manager with Boston Indicators, which is the research center at the Boston Foundation. And I've appreciated hearing the conversation with Dr. Simon and Jessica's testimony, and I'm here to provide an update on mental health among Boston Public School students based on the 2021 Youth Risk Behavior Survey. Counselor Anderson and Dr. Simon have already spoken to it as well, but hopefully this will still expand your understanding of mental health among Boston's youth. So the Youth Risk Behavior Survey is a national survey designed by the Centers for Disease Control and Prevention to monitor youth health behavior and experiences that affect long-term health and well-being. Now, BPS administers the survey every 2 years to a sample of middle and high school students, and the most recently available survey results are from 2021. So looking at the results by some health measures, BPS students are doing fairly well, but unfortunately, indicators of mental health are more unequivocally negative. The Youth Risk Behavior Survey asks a question about feelings of sadness and hopelessness as a way to monitor depressive symptoms, which I believe Counselor Anderson and Dr. Simon have referenced. So I'm going to just pull up my screen here. Are you seeing my screen okay? Great, okay. So here you can see the results from that question on sadness and hopelessness, both nationally and among Boston Public School students. In 2021, students reported feeling sad at the highest rates in over 2 decades. As you can see, the rate has actually increased slightly, slightly more among Boston students than across the country, and reports of feeling sad or hopeless also increased by 9% among Boston Public School middle school students. Now, unfortunately, some students are acting on those feelings of sadness by attempting self-harm. The rate of BPS high schoolers who reported doing something to hurt themselves, such as cutting or burning themselves on purpose, increased at a statistically significant rate between 2019 and 2021, jumping from 15% to 19%. However, reports among high schoolers of seriously considering suicide, which I'll refer to as suicidal ideation, or actually attempting suicide stayed pretty consistent from 2019 to 2021. That being said, middle school students are reporting higher rates of suicidality. The rate of middle schoolers considering suicide increased at a concerning rate, jumping from 23% in 2019 to 28% in 2021. Thankfully, suicide attempts decreased slightly between 2019 and 2021 among students in both middle school and high school. And when we looked at the results by demographics, we found that while most demographic groups have reported increasing mental health challenges, females, lesbian, gay, or bisexual, Black, and Latino students were more likely than their counterparts to report poor mental health. Youth who identified as lesbian, gay, or bisexual, or female reported much higher rates of sadness and hopelessness than their counterparts, and were much more likely to report self-harm, suicidal ideation, or attempting suicide. Students who identified as lesbian, gay, or bisexual reported suicidal ideation at 3 times the rate of straight students, and actually attempted suicide at nearly 6 times the rate of straight students. Female students seriously reported suicidal ideation and attempted suicide at rates roughly double that of male students. So both females and lesbian, gay, or bisexual students reported being bullied and experiencing sexual violence at higher rates as well, which could have played a role in their mental health declines. And I'll note that the WIRE-BS results are not available for students who identify as non-binary or transgender, because only female and male are offered as response options to the survey's questions about gender. BPS added a question about transgender identity to the 2021 survey, but those results aren't publicly available. So now looking at the results by racial group, Black and Latino youth pretty consistently report poorer mental health than white and Asian students. So in 2021, 48% of Latino youth and 44% of Black youth reported feeling sad or hopeless, compared to 38% of white students and 33% of Asian students. And sadly, Black and Latino students also attempted suicide at higher rates. Now, one important factor for protecting and improving mental health outcomes is social connectedness. And in 2021, BPS added a question about school connectedness to the high school survey. So looking at the 2021 results for that question, we see that nearly half of high school students reported not feeling close to people at their school, and it was the same student demographic groups who reported feeling sad or hopeless at higher rates who were less likely to report feeling connected to people at their schools. So in conclusion, mental health among Boston Public School middle and high school students has declined in recent years, especially among females, lesbian, gay, or bisexual students, and Black and Latino students. While these results are concerning, there's hope that greater awareness about youth mental health will allow us to recognize problems early and identify pathways to alleviate them. And I just want to note that all the findings I shared today are available in a 2023 Boston Indicators research brief, which you can access via this QR code or at bostonindicators.org. So thank you so much.
Kelly, thank you so much for that informative presentation. Much appreciated. We'll just keep moving right along. In the interest of time, to Steph de Normand from Fenway Health. Steph, floor is yours.
Yeah, thank you. So as you said, my name is Steph de Normand. I use they, them pronouns. I am the manager of our trans health program here at Fenway Health. Fenway Health is a community health center, as the name would help you predict, right outside of Fenway Stadium. And we have primary care, behavioral health, dental optometry, and a whole suite of other services available. Our focus population is on LGBTQIA+ folks within our communities. We also have robust research branches, education branches, public health sectors, and a whole bunch of other stuff that I could certainly dig into. Should we have the time, though I suspect we won't. I am mostly here today to spend some time to talk to you all again about our youth and making sure that folks can access that behavioral health services when they need it. When I was initially speaking with our director of behavioral health about coming here and speaking with you all today, it immediately for her brought us to speaking about our work in behavioral health integration within our primary care settings. While clinical spaces are not always the right place for folks to be accessing behavioral health services, and certainly there are numerous barriers that we could speak to of folks getting into clinical settings, we know that also every single touch point that we have is one that we should be thinking about and be finding ways to make sure folks can access services where they are able to. While accessing things like longitudinal therapy are a lot harder to make work without a formal diagnosis for insurance reasons, Joint Commission and standards of care reasons, ethical reasons around determining that medical necessity and then documenting that medical necessity, integration of behavioral health services into primary care spaces is a far lower barrier way for folks to get access to those services. One of the programs that we've been piloting recently, or kind of re-piloting recently, has been having behavioral health clinicians kind of rounding on floors during our typical primary care clinics and available for those kinds of check-in moments, those things that come up with positive screeners, or just in the conversation with someone's primary care provider, especially when those are healthy and robust relationships. All kinds of things can come up in those conversations with primary care providers that may be better suited for a licensed behavioral health clinician. We have the ability to provide a handful of visits in those circumstances with a behavioral health clinician where we can, provide stabilization resources, referrals out to that more longitudinal therapy when it is a resource that someone is interested in or is applicable for that person. But what we've been finding in both our own work and in communicating with similar clinics around the city is that we're really not able to generate enough revenue in providing those services to even pay for the clinicians who are attempting to provide that service. And that has been a really significant barrier for a large portion of the clinics who have been trying to create these models of integrated services. We have found, at least in my conversations again with our director of behavioral health, that sometimes we're able to get some of the private insurances to cover some of these conversations or be able to reimburse us to some degree, but especially with some of our public insurances, it's really challenging for us to find ways to make sure that we can create a financially sustainable model while also providing the services that we desperately want to be able to provide. Coming and speaking to you all from our clinic, I would be remiss to not speak a little bit about the kind of scary statistics that we're seeing with LGBTQI plus youth. There was a survey in 2023 that the Trevor Project did that found 56% of LGBTQ young people who wanted mental health care in the past year were not able to access it. And that is, for me, quite a startling statistic. And we are also finding significantly worsening mental health, depression, frequent mental distress, and all of these things for both adults and youth across the country. There was a recent research letter that was published in JAMA Internal Medicine by some of our colleagues who documented that with trans and gender diverse adults in particular, the prevalence of depression has more than doubled in the past 10 years, and experiences of frequent mental health distress have done the same. So these are certainly areas, whether we want to point to political climates, whether we want to point to things that are happening in our own backyard, so to speak, this is an area that we really have a lot of work to do. It can be really challenging for LGBTQI plus youth to also be able to take advantage of some of the larger services that are available out of not being sure whether or not those spaces are going to be culturally competent and able to, or experienced in working with their particular experience of the world, whether that is around their gender identity, their sexual orientation, or outside of that. So our work in trying to have those integrated models and having trained clinicians that are really integrated into a system that they're already engaging with is something that I was really excited to speak with you all today, to speak to particularly the spaces where we've had a lot of difficulty with funding. I, again, don't think it's a secret that we are having difficulty having enough behavioral health clinicians at all within the state, which has also been a challenge that we have found. And, I think having sufficient financial resources kind of comes full circle in that way. Being able to adequately compensate behavioral health clinicians and being able to fund the important work and work that they find, frankly, the most meaning in, being able to work with young people, being able to divert from folks developing those more severe mental health experiences, diagnoses, et cetera, being able to really make that significant impact in young people's lives. We want to make sure that that is something that is financially sustainable, both for the organizations as well as for the individuals who are providing that care, right? So these are all things that, while my testimony is a little bit short and sweet, hopefully, I wanted to make sure that I was able to spend a moment to talk about the behavioral health integration piece within our primary care and federally qualified health center spaces. Because I think is just one of those other touch points that we could certainly be taking advantage of, and I'm happy to chat more about any piece that folks want to hear more about.
Steph, thank you very much. We'll get right into our questioning. Councilor Fernandez-Anderson, the floor is yours.
Thank you, Mr. Chair. Thank you, Jess, Kelly, and Steph. I really appreciate your testimonies. Very, very helpful. It gives me more reasons to say that, I wish, DCF and BPS and everybody else, CMH, was here, but we can just continue the conversation. This is a great start. Steph, I'm really interested, in the integration model that you're talking about, and you mentioned cultural competency. So in terms of, professional development, how are we preparing for that in terms of practitioners, and what other types of competencies or professional development have you guys thought about in order for it to be appropriate for your patients?
Yeah, absolutely. So we have a number of different kind of training programs that we run in order to help our clinicians keep up not only with the clinical competency that they absolutely need and is essential for everyone. I would argue that having a robust understanding of gender dysphoria as a diagnosis and also as an experience for our trans and gender diverse folks, as well as a robust understanding of kind of how experiences around sexuality and gender impact the kind of larger systems within someone's brain and body are similarly important for everyone to know. However, we do find that similar to actually what Dr. Simon was talking about earlier, as well as what many of our panelists and other folks have spoken to so far, that having people who look like you, who have similar experiences to you, as well as really can display and show the knowledge in the experience that you're having, even if they are not perfect, if their own identity is not perfectly aligned with your own, are all really essential aspects to being able to sufficiently support someone. Whether that is thinking about the ways that trauma or the experiences within school settings, home settings, or other spaces, and the impact of someone's experience with gender, someone's experience with their sexuality, whether they are being welcomed in the identities that they hold or not. These are identities that are often discordant from someone's family or someone's other social systems, and being able to find community and being able to find spaces where someone can be supported in those identities is really, really essential in someone being able to then flourish and own those identities within themselves. Some of the training that we offer, a branch of the Fenway Institute, which is under our Fenway Health umbrella, is the National LGBTQIA+ Health Education Center. And they have a wide variety of on-demand webinars, as well as technical assistance and kind of dedicated work that they can do with individual health centers, clinicians, and all of that kind of stuff, as well as that on-demand webinars that offer things like CEUs. We also have a handful of conferences each year that are co-held by Harvard, who are specifically focused on advancing excellence in trans and gender diverse healthcare or in sexual and gender minority health. that we certainly encourage entire care teams to attend. So whether that is our medical clinicians, our behavioral health clinicians, community health workers, all the way across the spectrum, we want to make sure that there is adequate space and education for folks to understand both the kind of unique cultural aspects of LGBTQI plus identities, as well as the ways that those things overlap and intersect with medical and behavioral health spaces.
Thank you so much. That was super thorough. I appreciate that. And I've always thought about that because you get these surveys when you go into your primary care doctor, and where does it go, and is there continuity in terms of connecting to actual supports without a medical necessity or mental health medical necessity. Thank you so much. I really appreciate it. And more reasons why we do need funding to support clinics and organizations that are providing services such as yours. Mr. Chair, may I have just one more question?
Absolutely.
Thank you so much. Jess, I'll probably wait my turn to come around to ask you a question, but Kelly, I did have a question, a more immediate question about data. As we know it, in order for us to begin to look at how efficient we're implementing or we're executing services to clients, participants, patients, data is super important, research is super important, but more importantly, the quality assurance that needs to follow has to be based on research, real numbers. Are folks, not just the survey from schools, are you feeling sad? What are your experiences, suicidality, attempts, and so forth? But after the treatment, after connecting to resources, do folks understand their diagnosis? Do their parents understand diagnosis? Have they followed the treatment plan? Have they asked their practitioner for a copy? Do they fully understand it? Have they supported them monitoring at home? Those are the different things, implementations that have to take place at home in order for treatment to work, or in community, or in support of whatever domains. Have you thought about doing a deeper dive into research and data to analyze so that we can do proper quality assurance on mental health in general in Boston?
That's a great question. The Youth Risk Behavior Survey, which is a national survey that then districts or states can add questions to, doesn't go that deep into youth mental health, unfortunately. So it doesn't speak to diagnosis or treatment or reception to treatment or how treatment has functioned. And I'm not aware of a systematic survey that does do that, unless other panelists might be. I think they might have more expertise than I do. But I think that is a topic that's certainly worth investing more in research into, understanding the types of treatment that actually are working for students. So absolutely, I think that's something we could look into.
I really appreciate that. I think if that's a possibility, and I would be so interested in getting an update if that goes anywhere. If that's a possibility with the research. I do feel that CPHI services, as we know it, as a medical necessity under Mass Health or like your typical insurance, is a prison pipeline. And the reason being is these diagnoses are being just passed out so quickly. The clinician goes to the house, and if you do a survey, you will find that these clinicians, some or of a large number, is spending very little time with the child or with the youth, and then diagnosing within 20 minutes of knowing a child, which is crazy. It happens very often. If you do the research between the time of assessment to the time of billing on Mass Health, for example, you'll find that the time that is being spent before a diagnosis is way too soon. And then the services in terms of spending time, whether therapeutic mentoring or in-home or IHT, either way, you are spending very little time with the child because your caseload is huge. because there's not enough capacity, and then misdiagnosing or harshly diagnosing or overdiagnosing a youth with a thing that follows them forever is just so unfair. And then the treatment that follows, that the parent isn't equipped to support the child or the youth, and the community spaces. No one is supporting this treatment. And this is, I think, the majority of kids that are getting these diagnoses. And this is a huge problem for especially Black and brown or marginalized LGBTQ plus youth. So I just want to really spark that conversation. I think it's a direction that we should go into, and I really appreciate you being open to it. Thank you, Mr. Chair.
Thank you, Councilor. I believe Councilor Braden was up. She may have left. So, Councilor Mejia, you have the floor. Any questions?
Thank you. So I feel like I'm with family because this is the work. I may not be as, I may not have a decade of work as Councilor Anderson has, but definitely here for the conversation and happy. I know that the Department of Mental Health, there was, I believe Michelle Bodas is no longer there, but under her leadership, C-Plan, which is the nonprofit organization that I started, worked on Isaac's story. And so that little booklet that is translated in multiple languages, we worked alongside parents to develop that book. So really happy to see you all here in this space having the conversation. So I'm happy to be engaged. And before I ask some questions, I want to clarify, because the least that I want is, especially in a public forum, is for people to think that our office has been irresponsible. In regards to the project with the barbershops and the hair salons, I want to be really clear that they were not trained to provide therapy to folks. They were there just to be the liaison and connecting people to the support services that they needed. Here's a pamphlet, here who you can connect with. So I never want to give anyone the intention that barbershops and hair salon owners were out there giving people therapy. Nah, they were just providing insight to people and connecting them to the support services that they need. So for the record, Councilor Mejia was not being reckless here. But let's talk a little bit about the referral process, because having worked with clinicians of color in particular, there is a long, there is also a wait for folks to even get services. So can you all just share any insight that you may have around what the waiting time is for services and the impact that wait has on the social, emotional, and mental well-being of students? Because I understand there's long waiting periods even to be seen. And if anyone could talk to us about that and what, if any, work is being done to help alleviate that, I'd be curious to hear.
I can take a stab at it. There's an organization called, and they're the membership organization of all the outpatient behavioral health and substance use clinics in the Commonwealth. And they did do a survey about, how long is the wait to first appointment for youth and adults? And if I'm remembering right, I think it was about a 15-week wait for youth to the first appointment, which is obviously a really long time, and the family is struggling. And a long time, right, in the course of a child's life. And there's all clear data that you can intervene and receive services, the better the longer term outcomes. Something that is being looked at, there's, since the pandemic, outgrowth in telebehavioral health services, so virtual services. We saw a lot more of that during the pandemic. And if you kind of look at the data, since it's off for traditional medical services, but it stayed pretty consistent for telebehavioral health. And MAMH is actually doing a research project on that now, and I think it's kind of it's a little bit of a mixed bag. So in some ways, it's good, be shorter for telebehavioral health. And in some cases, for some services, youth might have access to a more diverse pool of clinicians by language, by race, ethnicity, by gender, by sexuality. But on the other side of the coin, we don't want to create this system where you can only have access to culturally competent care virtually, right? You want to be also to access those clinicians in person and in your own community, whether that's in a clinic setting like Fenway, or if it's like in the school. So so I guess to answer your question, there are long waits.
Yeah, yeah. Thank you for that.
Really long waits sometimes for culturally competent care. Yeah.
Sorry. You know, Jess, you're still breaking in and out, so I just wanted you to know I wasn't interrupting you. I thought there was a lag there and I jumped in, so sorry about that. And I think what works in Zoom is maybe you go off camera and then that will give you more bandwidth. If you haven't gotten that tip, I'm here to share it with you. But one more question that I have as it relates to just kind of what we can do in the between time for care, which goes back to the original reason why I believe we're here to talk about is kind of like alternate methods, right? So that is there a way, or has there been, or if you could speak to kind of connecting young people to other, so like I think Counselor Anderson mentioned yoga and or other I don't know what you call them, other you know, when you get other prescriptions, I guess, other prescriptions that will that do not begin and end with medical treatment, but that there could be some things that we can help young people like provide any other type of alternative prescriptions. Like you'll get a month to Planet Fitness, or like what other things are we considering to kind of deal with the waiting gap situation? And can you point to other things that you've seen other cities do to kind of address this issue that you can share with us that we potentially may want to explore?
Councilman, to anyone in particular, or to the panel?
Well, I mean, yeah, I mean, I don't even know if this, I mean, I'm just trying to, I'm a problem solver, so I'm always trying to look like, okay, here's the problem, and where are the, like, what are the multiple pathways towards identifying a way to meet this problem, right? So we have the Boston Foundation here, you're a philanthropic, you know, entity, you're also a research arm, right? So I'm going to assume, you know, that we have folks who are doing direct care and working with young people on a day-to-day basis, right? We have the Department of Mental Health. And so like with all of these resources that we have, I'm always saying that we're resource rich and coordination poor. Like when we look at the issue that Counselor Anderson has brought to the table, what are the multiple ways that maybe we create a fund, right? Where that it's a self-care fund for, you know, for a Boston Public School, or for, you know, Boston or whatever. It doesn't have to be Boston Public Schools, but like, is there a way for us to have a mechanism in place that helps address this issue that requires private and public supports to address this issue, and what that could potentially look like? Because some of the things that Counselor Anderson brought into the conversation are things that deal with medical insurance, and I think that those things are a little bit harder for us as a council to tackle. But the whole idea is to really look at what we can do as a city as a whole here in regards to addressing the immediate needs of young people. So I'm just here to inspire some thought and just figure out how we can address this collaboratively and creatively.
Thank you, Councilor. I appreciate it. Dr. Simon, you'd like something to add there?
Yeah. So in reference to Councilor Anderson and Councilor Mejia, last point. So recently the state has a collaboration with, I believe it's the Massachusetts Council on, I think it's Arts.
Yeah.
But the concept here is it's called art pharmacy, in so much as a family. So for an individual adult, or it could be for a youth, would be engaged with their primary care provider. Now, this is through one of the academic institutions in our city, Mass General Brigham. But the collaboration would be that you would engage and you could describe a subset of behavioral health, mental health challenges, and the primary care provider could prescribe like broad art here. So that could be to actual art painting, that could be to writing, that could be to going to the arboretum, that could be to any number of art cultural engagement that we know have positive benefits as it relates to mental and behavioral health. And I believe that the relationship is in the ballpark, I think, of $100,000 in reference to the art engagement. Because in part, if you have for instance, a 1 month subscription to going to an art gallery, let's just make that as an example, $100,000 in terms of that kind of service actually goes far much, longer than, as Steph was referencing, a clinician, you're talking about $80, $90, $100 versus the art component could be, something like $5 for the engagement over time. So that's one thing. And then I want to double back in reference to Councilor Anderson asking about follow-up. So, and I'm doing this only because Kelly, thank you for using your screen. So I just want to highlight some research that was done at BMC, and this is salient for the conversation here. And so this describes 6 stages of engagement. This is specific to ADHD. Treatment described by diverse urban parents, and I'll highlight Andrea Spencer, again, BMC, and just want to highlight, and this is the kind of research that isn't done regularly, and so it's why it's actually very important that I'm highlighting it here. So they conducted a semi-structured qualitative interview, 41 parents, kids 3 to 17, who all had ADHD, who are all being seen in essence in urban or at BMC. Parents were 92% female, 75% English speakers, median income was $20,000. And the parents described 6 stages to the process of engaging in care as it relates to ADHD, which is a mental health condition, which unfolded like a developmental process. So 1, normalization and hesitation. 2, fear and stigmatization. 3, action and advocacy. 4, communication and navigation. 5, care and validation. And then 6, preparation and transition. The paper goes into detail about the 6 different steps, but I just want to highlight that there are research groups here locally that are trying to identify what does it look like to actually get the families that we care about into care. And again, just specifically to ADHD, a 6-step process that families are like, I didn't even believe this diagnosis. Okay, now I believe the diagnosis, but man, I don't believe this medication. Okay, wait, the school's still calling and saying that my kid has to be suspended. All right, okay, what's the medication? Okay, now I gotta believe the provider. So there is a lengthy process that happens in terms of engagement. So be it Stephen, you're referencing Fenway, I have seen patients who are in their mind living a certain life, but then outwardly in their environment, i.e. in their home, they gotta live a different life. And they'll say, when we talk, you can call me, I'm just gonna use my own name, you can call me Kevin. When my mom's around, call me Julia, because that's what they want me to be identified as. And that kind of process and that kind of engagement and conversation, it takes so much time. And when I say time, more than one session, I'm talking about months of time. And so I think Councilor Anderson, I appreciate you referencing the 5, minimally 5 kind of ACEs and trauma that our young people experience. I often do share with families, yes, you're meeting me at 16. It does not mean it's going to take 16 years to resolve the respective challenges, but it's going to take time. And so I just appreciate the conversation that we're having, and the resource allocation is necessary for community agencies, because I often say it should not be normalized necessarily that you see me every week. That's very odd. You should be able to go to camp, go to school, have friends, have peers that you're engaging with. And yes, you should be able to have a check-in. And so I appreciate just highlighting the Division of Insurance and DMH highlighting the coverage. But we have to really boost and support our community agencies that really do the lion's share of the work. Because it's not, again, it is not in the clinic that a lot of the change actually happens. I can probe, I can get you to think about something, but it's really in the environment where people get that coach that they like, the friend that they're with. And so that's why at BPAC we really want to emphasize really working with communities. So I just want to highlight those two things.
Yeah, and I want to know for the record, Councilor Fitzgerald, Chair, before you move on, is that half of what he just said was in reference to Councilor Anderson, so that took up like 2 minutes of my time. I just want you to know, and I'm here for all of my time, so I want to regain some of my time, Councilor.
Did you see me take it away?
I
haven't taken away anything.
I've been traumatized, and Councilor Anderson, it says it takes 2 years for us to get over things, and you know what?
Dr. Simon has a PhD in some other things. So,
yeah, no, I'm telling y'all have no idea.
It's all good. We're only joshing you, Doctor. You're doing a fantastic job, as is everyone on the panel. Councilman Mia, please continue because we do want to keep. I just want to see if there's public testimony after.
Don't be trying to rush me off after he took all my time, and Councilor Anderson did too. Okay, so no, I'm really excited to have this conversation because someone talked about art. And art does heal, and I keep going back to the things that I've done because that's the only point of reference that I have. We created an art healing tour since the inception of COVID because there were a lot of folks who were dealing with isolation. So it wasn't me, it was an art therapist that created this whole program where we convened people, and for 2 hours they disconnected from the world, broke bread, and painted something that was therapeutic. And so this is our 5th year doing the art healing tour across the city. And what we have learned in that process is that something as being able to disconnect from your reality, that people have come in with feeling a lot of anxiety and or anger or whatever it is that they were experiencing. But by the time they were done with the session, their psychic or their emotional well-being was in a whole different stage, and I'm just curious as we continue to have these conversations, because the Boston Public Schools have removed art from all of the things that help support young people oftentimes are the things that we're taking away in our Boston Public Schools. So you mentioned art, and I'm curious, as providers, as folks who are doing this work on the community side, what recommendations can you share with us to push BPS in particular around art therapy?
I don't want to speak for BPS, but in reference to the comment about art, physical activity, I believe that BPS is reconsidering some of their curricula and are in collaboration with, yes, some of their staff, yes, community members, and then those of us at BPHC. But I guess I just would echo arts are critically important. I know for the city, we have a Department of Arts and Culture where we're thinking about different ways to collaborate with community. So anything that would be supportive of arts and culture broadly would be being supportive of mental and behavioral health.
Thank you for giving me the time, Councilor Anderson, for bringing this to the floor. And Dr. Simon, I'll be inviting you to our tour so that you can pop in at any of the events that we're going to have across the city of Boston. Thank you.
Thank you, Councilman Hia. With that, we'll move to see, first of all, I'd just like to thank the panel very much, all 4 of you, for being here today. Quite a lengthy conversation and a great one about, a very important need. It's funny, we talked about it yesterday in doing something for someone who helps someone in recovery with substance abuse, about how you can't give your best to the world if you're not your best self, right? And so you've got to take care of the inward self before you're able to to really help others, and we need a lot of help in helping others. So we want everyone to be in their best mental, physical, spiritual shape. And so thank you all for your work in helping do that, and for taking the time today to educate us on how to move forward. So we really appreciate the panel, and to the sponsor for bringing this, Council Fernandez, for bringing this forward. I don't know, do we have anyone for public testimony, Cora? We had 0 originally. I don't know if anyone has signed up.
No, we don't have anyone.
Great, thank you so much. So with that, closing remarks, I think I know I want to be respectful of people's times. If everyone's okay, we're ready to wrap this meeting up. Sponsor, you okay with that? Great. Well, with that, this hearing on docket 0478 is adjourned, and I'd like to thank everybody for their time. Thank you.
Well, Councilor Fitzgerald, sorry, I did have a closing remark. I don't know if you.
Well, you can put it in. I just officially adjourned,
thank
but
you.
please take your time.
Fictitious gavel there. Oh, you have your hand. Okay. I just wanted to thank you so much, Jess, and I learned so much from you. I took careful notes on every resource, and my office will definitely be reaching out. Carrie, really appreciate the work. I am always waiting for your department to put out another research, and I print it all, I highlight and study it thoroughly. Love the work that you guys do, absolutely. So really appreciate you, and we'll definitely be in touch as well. And Steph, amazing work. I appreciate the Fenway and all the work that you've done. Always been able to, I know that if people were overcrowded or clinics were overcrowded, the Fenway always makes a way. And I just, over the years, just appreciate and adore you guys. So thank you so much for all the hard work you do. And Dr. Simon, learned so much from you today. I think this will probably be some sort of continued conversation, maybe not necessarily a hearing, but a meeting where we can convene all the experts and minds and sort of look into, just sort of, as counselors, we're representatives, we're the voice of the people. In terms of the direction, really interested in the numbers, the capacity that you're building in terms of the non-diagnosed or temporary services with the initiative that you mentioned. I'm very interested in that because I think, the more the merrier. This is actually something that I think takes the pressure off of clinicians in schools as we know it, and so sort of allow them more flexibility and autonomy to be able to spend more time and more quality with the client or the student. So looking forward to those conversations, and I appreciate all the work that you do and learn so much from everybody here today. Councilor Mejia, I think I always tell you, creative and a genius with ideas. Would love to collaborate with you. We're doing a mental health art therapy program with BHA. They're going to put out RFP. Would love to collaborate with you. And Mr. Chair, this has been amazing. And as always, thank you for your thoughtfulness.
Excellent. Thank you so much. That will end the meeting the hearing is adjourned. But thank you all for your time.